afternoon and welcome to the MASH Bootcamp. Jordan, you did a fabulous job and you set the stage for me. I'm going to convince you that we can do non-invasive tests and do not need to do a biopsy to look at MASH. So my name is Lisa Richards. I'm a nurse practitioner. I practice at UC San Diego Healthcare in San Diego, California. And my presentation today will be looking at identifying patients that have stage 2 to 3 liver fibrosis and utilizing non-invasive tests to diagnose them. I would like to take a moment to thank the organizers because it's a great pleasure to be here today. So thank you. These are my disclosures, none relevant to today's discussion. So over the next 15 minutes, we're going to be looking at the importance of liver fibrosis. We're going to look at the types of non-invasive tests. So specifically, I'm going to approach it with blood and imaging biomarkers. And then we're going to wrap it up with a case study presentation to utilize the application of the non-invasive tests. We know that liver fibrosis is really the major driver for concerns about liver mortality. And we identify significant liver fibrosis as stage 2 or higher. And why is this important? Because mortality rates increase, liver-related mortality rates can increase. And so our goal as practitioners is that we want to identify these patients that have at-risk fibrosis, and that's going to be stage 2 fibrosis or higher. So we'll start off with a clinical case study. Jordan did a great job of setting the stage for me. So this is a 52-year-old obese female. Her BMI is 33. She has elevated liver enzymes. Her primary care provider ordered an ultrasound. The ultrasound showed increased echogenicity, which is consistent with hepatic steatosis. You can see her alcohol history. And again, Jordan touched on the fact we need to make sure that this is not MET ALD. So her alcohol history is 1 to 3 times per week, which is not considered to be at-risk drinking. She has cardiometabolic features that Jordan talked about, where she has type 2 diabetes, hypertension, hyperlipidemia. And importantly, on physical exam, we're not seeing any signs of advanced liver disease. So no stigmata of advanced liver disease. However, like most of our MASLD patients, she's going to have some central adiposity. You see her laboratory studies. And what I would just point out to you is that her ALT has been elevated at least 1 to 2 years. And this is a time to really make a point that what is a normal ALT for a woman? 19 to 25. So let's make sure that we keep that in mind. So she, based on all of this presentation, she's diagnosed with metabolic dysfunction-associated steatotic liver disease. So what I want to propose to you is that in 2024, we have non-invasive tests that we can use to identify our patients that have at-risk fibrosis or at-risk MASH. What I'll talk about is imaging biomarkers that actually detect hepatic steatosis. Because of time, I'll be focusing on 2 of the ones that are most utilized, and that's the CAP and the MRI PDFF. I'll be looking at imaging biomarkers that look at liver stiffness, and we'll look at the VCTE, otherwise known as the FibroScan, and the MR elastography. I'd also like to touch with predictive rules for fibrosis. So there are several blood tests that we can do to help us rule in or rule out advanced disease. The one I'll focus on today is the FibroScan. And then there's proprietary serum markers that look at fibrogenesis, and specifically we'll look at the ELF. And then I'll end up combining these non-invasive tests so that we can confidently identify our patients with at-risk MASH. By looking at the FAST, the MEFIB, and the MAST scores. So the FibroScan calculator is something that we can utilize point of care while we're seeing a patient to rule in or rule out advanced disease. And this is looking at a patient's age, looking at AST, ALT, and their platelet count. Now, later on in the discussion, I will be giving you cut points, and we'll look at this rather carefully. But this is a really good on your phone using this app that you can help primarily risk stratify these patients, ruling in or ruling out advanced disease. Now, the ELF that I mentioned is the Enhanced Liver Fibrosis Score, and this measures three different serum markers that look at fibrosis. And it's important in that its diagnostic accuracy, as you will see, is very, very good, and especially with identifying advanced fibrosis. And there are cut points for the ELF stage 2 and stage 3 of 9, which can give us an 85% sensitivity. Now, the ELF is really good if you have a patient whose BMI is greater than 35, so FibroScan probably wouldn't be the best choice, or you have a patient that's not able to get MR elastography. They have confounding parameters that will prohibit them. They might have a pacemaker or other elements. So the ELF is a great tool to actually rule in significant advanced fibrosis. Now, looking at non-invasive tests of liver stiffness. Remember, liver stiffness correlates to liver fibrosis. So there are several different modalities. What I'll speak on today is transient elastography, or vibration-controlled transient elastography, and I'll talk about the MR elastography. Now, you can see, do we have a pointer on here? Probably. If I point, I'll turn the slide machine off or something. I always do technical fun stuff like that. So what you can see in the upper right-hand corner is you can see what a VCTE would look like. So it creates a propagation map that gives us shear waves that we look at. And on the right, you can see an elastogram that an MR produces, and it's a multicolored elastogram. And so the different colors correlate to liver stiffness, red being significant liver stiffness. Now, VCTE is fantastic because it's point of care. I can do this in my exam room, and I can rule in and rule out advanced disease. I can also look at hepatic steatosis. So when you look at the VCTE, again, it helps us with liver stiffness measurements. It quantifies hepatic steatosis. And both of these are tools that we can use to identify patients that have MASLD. However, as a provider, we need to be able to ascertain whether or not the FibroScan is a quality FibroScan. And there are several things that I would propose to you that we need to look at. Number one, were there 10 valid measurements? Number two would be, what does the image quality look like? So you can see here, this is what they create as a propagation map. So you'll have 10 of these pictures here, and you want to look at the shear waves, and you want to make sure that they're parallel, that the image quality is good. Most importantly, you want to look at the IQR median ratio, and if it's greater than 30%, then you're going to question the quality of this FibroScan. And again, it's going to be operator dependent, right? So you need to make sure that whoever's doing the FibroScan, MAs do FibroScans in our practice, that they're trained appropriately. However, there are confounding principles that can limit FibroScans and things that we need to consider whether or not the patient can have a FibroScan. And that would be laboratory factors and also patient factors. So when we're looking at a patient that their aminotransferases are greater than 100, or they have cholestasis, that can artificially elevate liver stiffness measurements. Also, if the patient didn't fast, and I'm dating myself, but those of us that treated hepatitis C, and remember there were insurance parameters about what okay. So you can artificially inflate liver stiffness. And then also alcohol use. So I tell my patients, I don't want them drinking alcohol 48 to 72 hours before they have the FibroScan. Ascites can certainly impact that. But most importantly, for our patients that have MASLD, if their BMI is greater than 35, that's a problem. Now, I can tell you most of my patients have half of my patients have a BMI over 35. So that can be a limiting factor for us utilizing a FibroScan. MR elastography uses shear wave technology. It uses an acoustic driver that's placed on the patient's right side, and it produces that multicolor elastogram that I showed you that's on the right-hand side here. MR elastography is very accurate. However, there are considerations that we need to be aware of. One is, can the patient hold their breath? So do they have COPD? Do they have pulmonary issues that are going to cause problems? Is there hepatic congestion or iron overload? Again, that can cause a failure rate for the MRE. And then really the BMI, I would encourage you to know the limits of your MRI machine. Our MRI machine can go from 300 pounds to 450, and you want to know the diameter, the bore of the MRI, because based on the patient's body habitus, can they fit into the MRI machine? But I can say probably that my number one problem with MRIs is claustrophobia. Patients freak out. And so it's a very difficult exam. And so I try to talk them through it. I volunteered to have an MRE one time because I wanted to know what my patients went through. And I was so embarrassed because I got so claustrophobic. I had to pause for a minute. And I thought, oh my gosh, and I'm not that big, but some of my MASL patients are big and they're touching, the MRI machine. Okay, so this is kind of the meat of the next, what I want to talk to you about is how do we rule in and rule out advanced disease? And we use biomarkers. My goodness, let's see here. I'm dating myself. And that doesn't help either. Okay, so so if you see me kind of going over here a little bit. So we can use indirect serum biomarkers, and that's that FIB4 that I was telling you about. And you can rule in and rule out based on these cut points here. So you can rule out advanced disease if the cut point is less than 1.3, but you can look at concerns for significant or advanced disease if it's 2.67. The direct serum biomarker, as I mentioned, is the one called the ELF. And the ELF is very helpful in identifying patients that have significant to advanced disease. And you can see the cut point here. Cut point of greater than 9.8 is a really high positive predictive value of looking at ruling in advanced disease. The problem is you don't know if the insurance is going to cover it. So that's a concern that you have. And it's a send out lab. Looking at imaging fibrosis markers, VCTE, as I mentioned, the MRE, you can see the cut points of ruling in and ruling out. When we look at the VCTE, if it's greater than 12, then that's helpful in us identifying the fact that we think this patient has significant or advanced disease. It's nice because you can do it right in your exam room, and you can stratify the patient quickly by looking at the VCTE. And then the MRE, as you see here, you can see the cut points. If it's greater than 3.6, highly accurate, looking at liver fibrosis. However, as I mentioned, there's a lot of confounding factors where patients can't have it and or, did you just see that happen? Okay. It just advanced through my whole talk. I'm like, okay, there it is. Okay, perfect. Thank you, whoever just did that. So anyways, MREs can be a problem because the insurance won't cover it. And that happens to me a lot. They won't cover the MRE. So what I think is important, really take home points for you today, is that we can use combined sequential non-invasive tests. We can use an MFIB that looks at MRE, looks at FIB4. We can use, and I'll go through cut points in the next slide. We can look at the FAST score that looks at the VCTE, the CAP, and the AST. We can also look at the MAST score. Now, the FAST and the MAST score are on your phone. You can use this under medical calculation. So let's look at the cut points for these. So if we want to identify patients at risk NASH, we can use the FAST score. And the FAST score greater than 6.67 is very likely that the patient has at-risk NASH. And you can see here that it has a specificity of 90%. So that's quite high. The MAST score, if it's greater than 0.242, again, it has a very high sensitivity of identifying these patients with at-risk MASH. The MEFIB, FIB4 greater than 1.6, MRE greater than 3.3, likely this patient has at-risk MASH, and it has a very high predictive positive value on this. The CT1, this is very interesting. This is an novel MRI modality that you're going to see a lot of it in the future. And what it looks at is it's able to differentiate between MASL, remember just benign fat in the liver, or steatohepatitis. And they're looking at certain cut points here. However, further validation is required, but I think you're going to see this a lot in the future. So let's go back to our case study. So we know this patient has metabolic dysfunction-associated steatotic liver disease. What do? Well, we used our FibroScan to risk stratify her, and the FibroScan was 1.62. We did a FibroScan where it was 9.3, and the FibroScan met quality criteria. So I'm confident that the FibroScan was good. What we can do now is use the AGA clinical care pathway, where it looks at identifying patients at risk. We want to, of course, as Jordan spoke about, we want to rule out other causes of chronic liver disease. So we've done our due diligence and we've ruled that out. And then you can see the cut points for FibroScan. So you have less than 1.3, that's considered low risk. You have greater than 2.67, that's considered high risk. And then you have this indeterminate risk. So our patient falls in the indeterminate risk. And I would say probably 2/3 of my patients in clinic will fall in this category. So what do I do next? Well, I work with Dr. Lumba and we do a lot of MRIs. And so guess what? We did an MRE elastography and the MRE was 3.4. So what does this tell me? Well, again, confidently, I can combine NITs to diagnose my patient at risk MASH. And so we know the MRE is 3.4, the FibroScan was 1.62. Based on the cut points for MEFIB, she has a positive MEFIB, and I can confidently say that she has stage 2 fibrosis with 90% positive predictive value. So what about if you're practicing and you don't have an MRI? Well, we can use the FibroScan, the VCTE, the CAP, and the AST. And utilizing this FAST score, we can see that her FAST score is 0.67. And again, if it's greater than or equal to 0.67, you have a 90% specificity. So what I'd like to close with is there are MASLD pathways that we can utilize. To me, that one, the AGA one, is a little bit simpler to use. The one on the right is the ASLD pathway. Both of them look at risk stratifying the patient based on the FibroScan score. And then they have very detailed direction on what you should do next. And so I utilize this a lot. I also utilize the AGA one where I show my patients, I say, look, you're falling in this very low risk category. We can, send you back to your primary care provider and we can go ahead and, follow your FibroScan score in Epic at our facility. We have a dot phrase and the PCP can go dot FibroScan and they can come up with that. And in my note to the PCP, when I'm returning them, I give them parameters of when I want them to send the patient back to me based on the FibroScan. So thank you for your attention.